Hello, I'm Anju Peters. I'm an allergist from Northwestern University in Chicago, Illinois. Thank you for joining us. Our presentation today is an improved assessment of severity and novel management strategies to alleviate the burden of chronic rhinosinusitis with nasal polyps, or CRSwNP. This activity is provided by Integrity. The activity is jointly approved by Global Education Group and Integrity. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals and Sanofi. I'm excited. I'm joined by Dr. Amber Patterson. Dr. Patterson, if you'd like to introduce yourself.
Sure. Welcome, everybody. My name is Amber Patterson. I'm an allergist and immunologist at Ani Allergy in Findlay, Ohio, and we're excited to have you here tonight.
Thank you. So very important, how to obtain CME, CE credit. To receive CME credit for participation in this live webcast, you must complete the pre-test, view the program content, which we tell you is really good, complete the post-test and evaluation form. A link to the post-test and evaluation form will be provided at the end of the program, and your certificate will be processed and emailed to you within 4 weeks after we receive the completed form. So as mentioned, I'm Anju Peters, and you met Amber as Patterson as well from Toledo, Ohio. Here are our disclosures. The learning objectives today are to discuss how to apply evidence-based guidance to assess the severity and quality of life impact of chronic rhinosinusitis with nasal polyps, or CRSwNP. Second, to describe how to incorporate current guidelines and expert recommendations into the positioning of biologic therapy, sinus surgery, and oral corticosteroids for the treatment of patients with CRS with nasal polyps. And finally, to summarize the clinical trial data on the efficacy and safety of biologics and surgical options for patients with CRS with nasal polyps. So let's start with the disease burden of CRSwNP. So what is the prevalence of CRS with nasal polyps and CRS without nasal polyps? And CRS without nasal polyps is abbreviated as CRSwNP. We won't be talking that much about it, but overall, we think 12 to 16% of the US population has CRS or chronic rhinosinusitis. So 28.9 million American adults have CRS. So it's very common. Of this, majority of it, about 80% is CRSwNP, and 20 to 25% is CRS with WNP. Why do we care so much about CRSwNP? In general, we think it tends to be the more severe variant. In terms of disease severity of CRSwNP, patients complain of a lot of symptoms: headache, facial pain or pressure. They may have interior or posterior drainage. One that goes hand in hand with nasal polyps is loss of smell or hyposmia with reduction in smell, which can really impact quality of life. Nasal congestion or blockage is another very common symptom for patients with polyps. They may have other nasal symptoms as well and can have extranasal symptoms and comorbidities that we will talk about. So in general, congestion, loss of smell, think nasal polyps. Facial pain, pressure, discolored drainage is more common with CRSwNP. Oh boy, we may be frozen here.
Dr. Peters may need to log in and log back out. She seems to be frozen.
And you'll have to co-host her again.
You know what? You are going to have to forward it if that's okay. I'm joining you on my cell phone right now. This is really unfortunate. Can you guys see me? And can
Yes.
you keep forwarding the slides and I can go over it?
Chris, can you pull the slides up?
Otherwise, then I'm going to try again. This is really unfortunate.
Stand by.
Thank you. And as soon as it lets me join it, that's perfect. So we were talking about disease severity and we talked about symptoms. Let's move on to quality of life. And Chris, we're all good right now?
Yes, we are.
Perfect. I'm actually just going to stay on my cell phone if you guys are okay with it. So in terms of impact of quality of life, CRS with nasal polyps can disturb sleep. If you're congested, you don't sleep well. It can really have a social impact. Patients are often tired. They're always stuffy. They may get depressed or anxious, frustrated. They have reduced concentration for school as well as work, often embarrassed by their nasal symptoms, and really it does impact everyday activities. Next slide. So let's compare the quality of life of CRSwNP to other chronic conditions. We'll compare it to diabetes, asthma, and rheumatoid arthritis. Dark blue is CRS with nasal polyps. And when we look at quality of life, looking at physical component score, you could see CRSwNP is very comparable to diabetes and asthma. Next slide. And then if you look at mental scores, here you can see CRSwNP in blue is actually similar again to diabetes and asthma and lower than rheumatoid arthritis. Next one. Another way of checking quality of life is something called EQ-VAS scores. Again, the higher the scores, the better. You could see the norm for the population. In dark blue is CRSwNP, and it's lower than other chronic conditions, diabetes, asthma, as well as rheumatoid arthritis. Next slide. So what do patients say about CRSwNP? They report many unmet needs. Next one. So what patients say in terms of burdens of nasal polyps, they often experience a major impact of CRSwNP on their daily lives as a result of many of the symptoms of CRSwNP. To most patients, the most frustrating symptoms are poor sleep quality, along with the mental effects of this, reduced smell, so either not being able to smell, which goes hand in hand with not being able to taste often, as well as nasal congestion. Next one. In addition, there's underestimation of the burden for CRSwNP. Many patients are incredibly frustrated, and they feel like that they're often their treating physicians don't realize how much of a burden it is, both on their mental as well as physical quality of life and social functioning. Next one. And what we do know is that because this can be such a burden, that it actually coordinating the care, which often needs multidisciplinary care, is often not done as well. And for patients, this is one of the most important unmet needs. Next slide. And so, we know we have good treatment options for nasal polyps with sinus surgery. Unfortunately, sinus surgery disease often recurs in almost 40% of people. And then patients end up getting often intermittent courses of oral steroids, not just for nasal polyps. One of the comorbid conditions of nasal polyps is asthma. So in addition to steroids for their polyps, they end up getting steroids for their asthma, which causes a lot of side effects. They may also potentially get steroids for their other type 2 comorbidities. Next slide. So let's talk about assessment of disease severity and quality of life impact. So there are many different ways that we can assess CRSwNP severity as well as quality of life impact. The ideal situation would be if we had one metric that very well told us how patients are doing. It told us not only disease severity, but it was responsive to treatment. Unfortunately, we don't have that. We have multiple different tools. So let's go over some of them. For clinicians, some of the tools that are available with endoscopy, you can assess the nasal polyp size, which many of you may be familiar from the phase 3 trials. Lund-Kennedy endoscopic score is a way of assessing inflammation in the nose and nasal cavities and sinuses. And then Lund-Mackay CT score or LMK-CT score, is a way to assess disease severity radiographically. It goes from 0 to 24 and is a very good objective measure of disease inflammation that we all, endoscopy, not everybody does, but CT scan, sinus CT scan screening without contrast is not that much radiation and really gives us good evidence of disease. Next slide. In addition to clinician-reported measures, there are also patient-reported measures, including you could assess symptoms and quality of life. One of the most common ones is SNOT-22, Sinonasal Outcome Test 22. You can measure nasal congestion score. You can measure smell by UPSIT or University of Pennsylvania Smell Identification Test. Chronic sinusitis survey, rhinosinusitis disability index, nasal polyposis quality life, many different ones. The main ones tend to be the SNOT-22 and nasal congestion score and UPSIT for smell. Next slide. In addition, there are other, not just disease-specific, but general quality of life measures, including SF-36, as well as what we talked about earlier, the EuroQoL EQSD. Next slide. So here's the SNOT-22. SNOT-22, not only has it been used in trials, but many of us use it in day-to-day basis, taking care of our patients with CRSwNP. It is a disease-specific, 22 items, well-validated. Values over 50 suggest severe disease. Some of the items that are highlighted that are very important for patients, and patients often say the most important ones are, again, congestion or blockage, loss of smell, thick nasal drainage, need to blow the nose, and post-nasal drainage. Next slide. So here's how polyp score looks like. And here you can see that the polyp score on each side is rated from 0 to 4. 0, no polyps. 1 is if their polyps are really small in the middle meatus. 2 is if they get below the lower border of the middle turbinate. 3 is if they get to the lower border of the inferior turbinate, so they're starting to get really large. And 4 is pretty much obstructing the nasal cavity. You add up the scores on both sides, and severe nasal polyps, which is what in most of the clinical trials is defined by polyp score greater than 5. Next slide. Here's a slide showing you, as I mentioned, there are many comorbidities associated with severe CRS with nasal polyps. CRS with nasal polyps is type 2 inflammation. This slide shows the top 3 comorbidities that are listed here, including allergic rhinitis, which is seen in 70-some% of patients with polyps. In the middle is atopic dermatitis, another type 2 comorbidity, seen in fewer, about 9%. And then asthma, which goes hand in hand with nasal polyps, is seen in over 50%. And what you see in this slide is severity of disease. Green is moderate severity, red is severe. And many of these patients have moderate to severe type 2 comorbidities associated with their nasal polyps. Next slide. And I'm just going to walk to get my phone charger, but we'll keep going. So one of the things we know is that CRSwNP is type 2 inflammation. And to tell if someone has type 2 inflammation, you look at key indicators for diagnosis of type 2 inflammation. And in fact, some of the ways we can tell type 2 inflammation is by looking at what's going on in the polyp tissue or what other comorbidities are present. Presence of late onset asthma is a type 2 indicator. Patients who have previously had surgery, and then you see eosinophilia in the histology, that's also a type 2 comorbidity. NSAID exacerbated respiratory disease, or AERD, is a big indicator of type 2 comorbidity. Other evidence of type 2 inflammation include tissue eosinophils when they're greater than 10 high power field, blood eosinophil greater than 150 cells, or total IgE greater than 100 IUs per ml. Next slide. So let's talk about the current treatment landscape for CRSwNP. Keep going. So what do we use in regular care of our patients? We already talked about surgery when disease is not medically controlled. Patients often get intermittent courses of oral steroids. In addition, we often use saline rinses, topical nasal steroid sprays, and one of our newer treatment options, and it's not really that new anymore, is biologic therapy. Keep going. So one way of delivering topical steroids is the exhalation delivery system with fluticasone or EDS flu. EDS flu literally just gets topical steroids deeper into the nose and goes around, and it's been shown to decrease inflammation. It is approved for nasal polyps. Next slide. So here's the data showing the efficacy of EDS flu compared to placebo. This is from Reopen 1 and 2 trials. There's improvement in symptoms. There's improvement in the composite symptom score, as well as improvement in sinus opacification compared to placebo. Next slide. In terms of safety data, EDS flu is very well tolerated. The only thing that I would like to mention, if you look on the fourth column, epistaxis is about 10.9% at the 372 microgram dose. It is about 5% in the 186 microgram dose. So epistaxis is the main thing that we watch for in these patients. Next slide. So we talked about surgery earlier, and I mentioned to you that about 40% of people will have recurrence despite surgery. So how do we know who will have recurrence? So risk factor for nasal polyp recurrence include the presence of comorbid asthma, AERD, or aspirin-exacerbated respiratory disease. These you probably all know, but just in case, are patients who have asthma, nasal polyps, and if they were to take a non-steroidal or aspirin, they have worsening of sinus disease, worsening of their asthma. Another risk factor for recurrence is AFRS, or allergic fungal rhinosinusitis, smoking. Some studies have shown presence of allergy. We definitely know presence of type 2 inflammation, as I discussed earlier. Prior surgery and younger age are all factors associated with polyp recurrence after surgery. Next slide. So other than surgery, steroids, rinses, the biologic is our newest treatment option, and it's actually something that has revolutionized treatment of not just nasal polyps, but asthma. The 3 biologics approved for nasal polyps include dupilumab, which targets IL-4 receptor alpha and targets IL-4 and IL-13 signaling, omalizumab, which blocks IgE, our oldest biologic, and mepolizumab, which targets IL-5, the eosinophil growth and survival factor. These are all approved for CRSwNP. The dosing for dupilumab is 300 milligrams every 2 weeks. Omalizumab is 75 to 600 milligrams every 2 to 4 weeks, and mepolizumab is 100 milligrams every 4 weeks. Next slide. So how do you decide which biologic to choose for which your patients with CRSwNP? So we're actually quite lucky. We have this paper that was part of our practice guidelines and was published by Paul Oikman and his group. And what this slide shows, they compared the 3 different biologics, dupilumab, omalizumab, and mepolizumab, as well as aspirin desensitization. Aspirin desensitization is indicated for patients with AERD. In this slide, anything that is dark green shows the best benefit. Blue, dark blue is among the least benefit, not different from placebo. Light bluish color is among intermediate benefit, and then red is most harmful. So as you can see, standard of care is then dark gray. Patient-reported outcomes include quality of life, such as SNOT-22 we mentioned earlier, symptoms, smell, rescue need for steroids, rescue need for polyp surgery. AEs or adverse events are in the middle, and then we have the surrogate outcomes. These are outcomes really important. However, a patient may not think of it as important on a day-to-day basis. These include nasal polyp size as well as CT scores. So you could see all 3 biologics and aspirin desensitization improved symptoms by visual analog score, which is the 3rd column. However, if you look at sense of smell, dupilumab does better than omalizumab or mepolizumab. and aspirin desensitization was among the least benefit. In terms of safety, these are all biologics are all quite safe, as you can see. The only one that is in red is aspirin desensitization, which, as you can imagine, high-dose aspirin may potentially increase risk of bleeding. In terms of surrogate outcomes, the three biologics compared, the one in dark green, dupilumab decreases polyp size the most, as well as improves CT scan severity of disease. Next slide. So a good part is we also have many real-world studies that have compared dupilumab to surgery. And this, I'm just going to show you two of them. In this one, where they had a matched cohort, what they found was that SNOT-22 improvement happens in both. However, the one that gets better more with dupilumab is sense of smell. Dupilumab-treated patients compared to surgery report better smell, decreased cough, decreased postnasal drainage. In terms of surgical cohort, what did they do better in? Their polyp size went down more compared to dupilumab. Next slide. In the other study, which was an observational cohort, both dupilumab and surgery worked well. They improved outcomes. However, in this study too, dupilumab was associated with more improvement in terms of runny nose, smell, and better control of local inflammation, as well as had reduced need for oral corticosteroid treatment with dupilumab compared to surgery. Next slide. So here's a table that just kind of shows how these biologics do. They all improve SNOT-22. They all improve nasal polyp size. They all improve sense of smell. As I showed you earlier, dupilumab does it more compared to the others, but all three also help asthma exacerbation, which is a common comorbidity, and improve quality of life. So all of these three are indicated for nasal chronic rhinosinusitis with nasal polyps in the US. Let's keep going. In terms of treatment selection and what is our therapeutic goal, just as in asthma and we see in other chronic conditions, remission has become a big goal for us in CRSwNP. This is from Euphoria. Euphoria is our European forum, mostly rhinologists, pulmonologists, some allergists. There are a few of us from US that are part of it. We defined control, remission, and cure for CRSwNP, and it got published earlier this year. Just like other conditions for remission and control and cure, you have to consider, do these patients stay on treatment or off treatment? In terms of control, we described absence of symptoms in the month prior on therapy. Remission we defined as no symptoms, no endoscopic sign of active disease or inflammation for 12 months or more, while people were still on treatment. However, cure we defined as sustained remission for greater than 5 years and off treatment. Next slide. So we do have some guidelines in addition to the one that I showed you earlier, where we compared the biologics and aspirin desensitization. This is the yardstick for medical management of CRS. This was a consensus paper in US. It was mostly some of us allergists and some ENTs. So in general, if someone has rhinosinusitis for 12 weeks or more, so CRS, the first line of therapy for all, whether you have with polyps or without, is intranasal steroids. You could consider changing the type of delivery you would use, either rinses, spray, or EDS flu. We recommended nasal irrigation with saline. Next one. In addition, once we treat someone and they're not getting better, you could try and phenotype them. Do they have polyps? Do they not have polyps? You could potentially endotype them. Do they have type 2 based on some of the markers we talked about, eosinophilia, IgE? You could do a CT scan. You could do endoscopy. And if they have nasal polyps, the next step in treatment would be, next slide. If they have significant polyps despite failure of first-line therapy, patients could consider surgery with removal of polyp or FES. Sometimes with biologics, if they have severe disease that tends to recur, for example, AERD or severe asthma, you could consider a short course of oral steroids. And sometimes you would consider biologics even before surgery, especially if this is a group that you think would recur, such as severe asthma or AERD. Next slide. In the AERD group, so if they have CRS with nasal polyps with aspirin-exacerbated respiratory disease, as I mentioned, surgery is an option. Biologics with or without surgery, or with surgery, again, you could consider, since this is a group disease recurs. Oral corticosteroids, just as in patients with nasal polyps. And you may consider aspirin desensitization followed by aspirin therapy long-term. Some of these patients also respond to leukotriene antagonists. Next slide. We also have an algorithm from our surgical colleagues. Some of us were part of this. In most patients, our surgical colleagues suggested sinus surgery, followed by post-op management, because CRSwNP is a chronic condition. And the treatment for that, next slide, would include topical steroid sprays or rinses. However, if they still don't get better, then potentially you would consider a biologic, a revision sinus surgery if enough surgery was not done, aspirin desensitization followed by aspirin therapy for patients with AERD. Our surgical colleagues also suggested you could use a steroid sinus implant where the steroid implant goes in there and elutes steroids, or you could consider short burst oral corticosteroids, same as we did in our yardstick guideline. The main thing with oral corticosteroids is you don't want to keep giving them repeated courses. Next slide. If you decide a treatment option, you'd assess response in 6 months. If there is persistent disease, you go back and try and think again, do they need surgery? Do they need biologic? Do they need aspirin desensitization? Next slide. What they did say is in majority of patients, they recommended sinus surgery. However, in some people, if there was contraindication for surgery, they had poorly controlled asthma, steroid-dependent asthma, or they couldn't get steroids, or they declined surgery, then potentially to consider a biologic. Next slide. So our euphoria guidelines also recommend how to decide when someone should go on a biologic. The guidelines recommend presence of bilateral polyps in someone who's had surgery. And the reason for bilateral is if you see a unilateral polyp, you have to think, could this be a malignancy, which is not common, but should be evaluated by an ENT surgeon. So in presence of bilateral polyps in someone who's had surgery, euphoria guidelines recommend 3 criteria. 1, it could be evidence of type 2 inflammation, as we discussed earlier. Eosinophils greater than 10 per high power field if someone's had surgery in their histology. You can ask your pathologist to look at it and help guide you. If their blood EOs are greater than 150 or their total IgE is greater than 100. Another criteria you could consider is need for systemic steroids or contraindication to systemic steroids to severe disease. How is systemic steroid need defined? It's defined by greater than 2 courses per year of systemic steroids or long-term oral steroids, low dose even. If they have significantly impaired quality of life, which you could assess by SNOT-20, if there's significant loss of smell, or they have comorbid asthma. So 3 criteria from these that are listed on the left. Next slide. So it's important to get the right biologic for our patient, but one of the first things we do before you say someone should go on a biologic, you want to confirm the diagnosis of CRSwNP that's not controlled. Check for comorbidities, treat them, asthma, allergic rhinitis, etc. Determine if they have type 2 inflammation because these biologics target type 2 inflammation. Discuss the different treatment options with the patient. We think about it as shared decision-making. This is on our college website, American College of Allergy, Asthma, and Immunology. If someone chooses surgery, they can go see the surgeon. If they choose biologic, potentially we could treat them with that. Some patients may end up needing both surgery and biologic. It all depends on disease severity and shared decision-making. Next slide. How do we assess how someone is doing on a biologic? Our euphoria guidelines also help with that. We can define response to therapy based on how someone does in terms of polyp size, need for steroids, improvement in quality of life, improvement of comorbidities and sense of smell. We recommend evaluation after 6 months of therapy. If someone has no benefit, to stop it. If they're having some treatment benefit, reevaluate at 1 year, but discontinue if they have no response to any of the different criteria that are listed. Next slide. With this, I will let Dr. Patterson come on. We'll have her discuss the case, and I'm going to try and see if I can get on the computer again. Let you get started.
All right, sounds good. I also had to switch over to my phone, so I'm going to turn off my video again just to save battery and make the internet connection better. While we start talking about the new referral you just got from ENT. Jeff is an 18-year-old male, and he was referred to you because of recurrent polyps. His problem started about 10 years ago. He was found to have severe nasal polyps in childhood, and this is really rare. So this is not something you'll see every day, but in this patient's case, at that young age, when they found polyps, they referred him to see pulmonology early on. They thought, maybe this is some kind of variant of cystic fibrosis. And so he was tested for that. Testing came back inconclusive, and all of the testing they had done on the lungs turned up normal. So he continued to be managed by ENT up until this point, and was told that he may have a CF variant that only manifests as nasal polyps, but there was nothing to really, make that diagnosis. So between then and now, he had been requiring annual polypectomy surgeries. But this last time in May of 2024, this time after the surgery, the symptoms started coming back much sooner. The surgery only seemed to last about 6 weeks, whereas in the past, it would last almost a year. So polyps were back, and the surgeon mentioned, when Jeff and his mom saw the surgeon to explain that symptoms were coming back so soon, he mentioned that on the last surgery, there had been some signs of fungal growth that he had not seen on previous surgeries, and so he had cultured that, and he wanted Jeff allergy tested to see if there were allergies contributing to his symptoms, and specifically if mold was something that he was allergic to, because he wanted him evaluated for ABPA. Jeff also mentioned that he can taste but not smell currently, and usually after surgery he can smell again for a short period of time. Overall, his most bothersome symptom is having a really stuffy nose, that nasal blockage, and because of that, always sounding like he has a cold. His mom said that is something that other people notice and really bothers him. And then he also seems like anytime he gets a cold, that it just lingers in his nose or sinuses, and it's harder to get rid of. He doesn't have any other associated symptoms or respiratory symptoms, no exacerbating factors that he can really pinpoint. And we're at a point where surgery is temporarily relieving symptoms. So other things that he has been doing are Flonase and saline rinse. And usually he does that until the polyps grow back and get to the point where they're occluding the nasal passages. Then he stops until the next surgery, but he's not really sure how effective that process has been for him. And his last allergy testing was about 3 years ago. Next slide, please. Which of the following risk factors for polyp recurrence does our patient exhibit? So this is your chance to say what you think here on the poll. Is it allergy, prior polyp surgery, younger age of onset, or all of the above? We'll give a little more time. We've got some answers still coming in here. Okay, with about half of us responding. The answer is all of the above. So each of these things is a risk factor for recurrence, and our patient exhibits all of these factors. Let's see, can we go to the next slide, Chris? There we go. Okay, the poll was still showing for me. Looking at the risk factors for polyp recurrence after surgery, we have underlying conditions, asthma, aspirin sensitivity, other Th2 comorbidities, and biomarkers that go along with that, like higher eosinophil levels, higher IgE levels. All of those things indicate an underlying Th2 phenotype that's driving the inflammation and encouraging the growth of those polyps. Postoperative care, if there's incomplete polyp removal or the patient doesn't comply with postoperative care, can be a risk factor for recurrence. Now, in our patient's case, it sounds like he's pretty consistent with his routine of post-surgical care. And his surgeons have been doing these operations on him for many years. So for him, that likely was not one of the reasons, but he's got several other reasons we discussed. Radiographic scores. So like Dr. Peters discussed, having a worse post-ESS MLM or Lund Kennedy scores. Disease severity. So patients that have higher recurrence in more severe disease. That's one of those chicken and egg things that you kind of wonder, okay, which comes first? But for patients that have more severe disease, they do have higher recurrence. Sinonasal outcome tests. So the post-ESS SNOT-22 scores, those that have the worst scores, the worst symptoms tend to have recurrence. And then those patient factors, being young and male are a big risk, and then smoking can increase that risk as well. Next slide. In reviewing outside records, you see that there was a nasopharyngeal culture performed at the last surgery. The ENT surgeon had mentioned that he saw signs of fungal growth and they had collected a culture. So that's something that we can take a look at. And also, there was some allergy skin testing done. Next slide, please. Which allergen should be tested in the evaluation of possible comorbid allergic bronchopulmonary aspergillosis? You guys are already rolling in these answers. There's Alternaria alternata, Aspergillus species, Cladosporium, or A and B, both Alternaria and Aspergillus. And we're somewhat split on this one. So the answer is Aspergillus species, but I think I can totally see where some of you are coming from, because in most cases, if you're testing Aspergillus, you're probably checking other molds and other environmental allergens as well. But for diagnostic criteria for ABPA, it is Aspergillus species that you would want to be looking for. Next slide, please. We were able to get the results of the nasopharyngeal culture. And interestingly, the fungal culture was negative, but there was staph growing. So he was treated for that. And then we decided to get some allergy skin testing in our office. And he was positive for Alternaria, but not Aspergillus. He was also positive to some tree pollens, and all the other respiratory allergens were negative. So ruling out ABPA and understanding that Jeff's symptoms are primarily focused on the nasal sinus area, how can we help him? Next slide, please. What intervention would you recommend as the next step for treating him? allergen immunotherapy to treat his allergies, stepping up to add a biologic, EDS-FLU, or revision ESS. And I think just focusing on what would be the next step, you may end up doing more than one of these over time. Okay, and about 75% selected add a biologic, and about a quarter suggested starting allergen immunotherapy. And both can be helpful, but for the purposes of this discussion, the next best step for quick relief with someone with a long history of recurrence of nasal polyps and really severe disease is adding a biologic. Next slide, please.
All right, Amber, thank you so much for this wonderful case. And I think in your case, that made sense. This person's had multiple surgeries. It would make sense to try a biologic. Immunotherapy for sinus disease, we don't have the best evidence. EDS flu, we do, so you could try that. So with that, let's talk about the summary and key points. Next slide, please. So CRSwNP, we talked about the high symptom burdens in patients with CRSwNP. It could be detrimental to their physical and psychological well-being. The effective disease management necessitates an accurate evaluation. You need to make sure they have WNP, establish the disease severity, identify the type 2 comorbidities, determine level of disease by different measures we talked about, and to best then decide the optimal treatment selection in our patients. Many of these patients may first decide to get surgery, and surgical intervention is recommended and can be effective for many patients with uncontrolled disease. However, about 40% of time, polyps may recur. In those patients or those who cannot get surgery, biologic therapies are safe and effective for moderate to severe CRSwNP. It is a good alternative to repeat surgeries like your patient, Jeff, Amber, and also for those who end up getting repeat courses of systemic steroids and still have disease for disease control. Next slide. With that, Amber and I would like to thank you. We're sorry for our little bit of our issues with Wi-Fi, but unfortunately that happens. Hopefully this all went through clearly. And we, again, want you to do your questions and try and get CME.
Thank you, everybody.
Thank you, Amber.